Hey everybody, welcome back to the ECG channel. My name is Reed, and don't forget to download this PDF down in the description below so that you can follow along. And feel free to like this video and subscribe to the channel if you enjoy the content. So let's jump into it. So the first thing we're going to note is that this is a Holter monitor, right? And Holter monitor, these are wearable devices that record from essentially just one direction your cardiac rhythm. So this is not a 12 lead, and this is actually a continuous strip. So this is just lines 1, lines 2, and lines 3, but they are all continuous with each other like you're reading a book. So we're going to start from the top, we're going to kind of work our way down. I thought this is a great rhythm example. And remember, Holters, what are they good for? You wear them for, up to a few days to a week, depending on which one you get. There's a ton of different wearable devices. And these are really helpful for when the patient comes into the office with a story that is concerning for some type of cardiac arrhythmia, but they're only there with you for 20 minutes, right? So that ECG that you catch might not be the ECG that you need, the rhythm that might be the diagnosis. So this is one that I had, and let's talk through it. So first thing we're going to notice is that we've got a pretty slow rhythm, right? It's narrow, complex, it's slow. You can see it appears to be, for the most part, somewhat regular, right? I would say the average rate right here is a QRS that lands on a solid line, right? And maybe that rate is 300, 150, 100, 75, 60, 50. That's 43, so this would be like, I don't even know, 35 beats per minute, right? At the end of the day, we know it's less than 43, it's slow, okay? So we've got a pretty severe narrow complex bradycardia, right? And so a narrow complex bradycardia, kind of what's our differential when we think through this? Well, we know that narrow complex means that the AV node is the kind of the region that's passing that signal, that narrow complex signal, down through the His-Purkinje system, through that rapid conducting system, creating our narrow QRS. So we could have like a, let's see, sinus bradycardia, we could have AV block, we could have a junctional, right? There's really not a whole lot on our differential, right? Maybe ectopic, maybe this could be like an ectopic bradycardia. So the next thing we need to do is figure out what's the atria doing. You see that we have P waves. You see that we have P waves in front of my QRSs. Right, I see P waves there. And if I look in between each beat, right, I look for extra P waves, because we said we might be thinking AV block. Well, if it's a high-grade AV block, like a second degree or complete, there should be P waves that are not in front of QRSs. And so I look all through here for P waves. I look on top of that T wave and I don't see any, so I see no extra P waves, okay? So I see no extra P waves. So I'm like, okay, so this is likely not, maybe not ectopic, right? It's not like a, a high-grade AV block, doesn't seem. But what's going on? Why am I showing you this rhythm? Well, I need to evaluate better the AV node by looking at these PR intervals. And so I can see this PR interval is a little bit of a first degree AV block, right? So we have a first degree AV block here, right? My PR interval is about 240 milliseconds, which 200 milliseconds is the highest that we would like to see. But if you notice, it seems like the PR intervals with each beat get shorter. Look, all of a sudden this PR interval is within normal limits, right? And so you're like, how are these getting shorter? And if you look down here, they're getting a lot shorter. So you're getting like intermittent shortening of the PR interval to the point where you're getting this. Look at that P wave. That PR interval is too physiologically short. So we're seeing PR shortening as we continue throughout this strip. So what could happen? Why would that be? What would be the cause of that? Well, my theory, which is likely the reality here, is that this person is in such a profound sinus bradycardia. This person is in such a, we know they're in a profound sinus bradycardia, right? So they have a profound sinus bradycardia. What does that mean? That means that the sinus node is beating super slow, which it is, right? Here's my P to P interval. That's really slow. So my P's are coming out really, really, really slow. And we know that we actually are able to produce a junctional rhythm from the AV junction right here. And those junctional escapes, right, those junctional escapes, what are they going to look like? First, they're going to be narrow, right, because if they beat, they're going to beat and send signal down that His-Purkinje system just like normal. And also their rhythm is typically at a rate of 40 to 60 beats per minute. So oftentimes you'll see what happens is if the sinus node gets bradycardic enough to where it drops beneath that threshold, right, look at that rate, for the junction to start taking over, you can sometimes see the junction start to beat. And sometimes that junctional rhythm, like you see here and like you see here, those junctional beats come at a time where the sinus node beats off here. It goes and it sends its signal down. We said the AV node, here you can see we've got a little bit of a prolonged PR interval. So in the time that the AV node was capturing that signal from the atria, it actually just sent out a junctional escape rhythm before it could conduct that signal down. So we're actually seeing a junctional escape rhythm that's occurring before this PR interval, before that P can even conduct that QRS. And that's why that is shortening, right? That PR interval, that P wave is trying to get down, but we have a junctional beat that occurs right before it could do so. And you see that happening here. Look how short these PR intervals are getting compared to the baseline. That's way too short, but it's all relative, right? This would be a normal PR interval in a normal healthy person, but we know that this AV node already is unable to conduct faster than 240 milliseconds, right? Because that's the best one we've even seen, and that might not even be the case. And so we've got a pretty good example here of somebody who has a sinus bradycardia, we would say, with a competing junctional rhythm, right? And if you wanted to explain this better, you could say a severe sinus bradycardia, right? This competing junctional rhythm is a normal physiologic response to the severity of this sinus bradycardia. That is why we have the junction, so that if we need to create escape beats so that our heart rate doesn't get too slow, we can still perfuse the body. So well done to this person's AV junction, poorly done to this person's sinus node. And we need to also now think, well, why is their sinus node so sick, right? Is this a, obviously clinical context matters. Is this an 80-year-old person with long-standing AFib? Well, they could have sick sinus syndrome. Is this an extremely young athlete, like a 20-year-old, college marathon runner who is at, rest at night? This is at 3 a.m. when they're sleeping. Probably less concerning, right? Because their heart rate's going to drop a little bit lower. So kind of depends on the situation. But I hope this helps you kind of understand how you work through this Holter monitor strip. I think it's important. ECG rhythms are great, but these are also great to just, you get more opportunities to see pathology that you don't always see on a 12 lead, right? And so a lot of you people out there, out there in the healthcare world, you get telemetry strips, people in the ambulance, all sorts of, monitoring devices that we use. So I hope this helps. And if you have any questions, put them down in the comments. Thank you so much for watching. Subscribe to the channel if you enjoy, and we'll see you on the next ECG video. Have a great rest of your day.